Okay, good morning, everybody. Welcome to our latest webinar. Our webinar title this morning is Treatment Planning in Aesthetic Dentistry. And my name is Professor Paul Tipton. I'm a specialist in prosthodontics. I'm Director of Tipton Training Limited in the UK and also President of the British Academy of Restorative Dentistry. So without further ado, let us crack on. So today with treatment planning in aesthetic dentistry, we're going to look at three major factors, three major criteria for good treatment planning to make sure that you understand everything that needs to go into aesthetic dentistry and how you see a patient, how you design a smile. We're going to look at the diagnostics first of all, what information we need to take from the patient to be able to design a smile. The second part is designing that smile. And the third part that I want to look at is the ceramic systems that we're going to be using. When do you choose to use one particular ceramic over another? So in terms of the diagnostics, let's start off with the diagnostics. And there's 5 or 6 aspects or 5 or 6 points that we need to collect. Items of information for us to be able to go and do a good diagnostic process. First of all, it's mounted study casts. Okay, and you can see down here, we're going to talk about mounted study casts. We're going to talk about the diagnostic waxing that's required, prototypes that we need to use, preparation guides, and cosmetic imaging. Now, on top of that, we also need photographs. The photographs will come with the cosmetic imaging, that aspect of it. We need to take radiographs. We need to do a thorough examination. If it involves implants, then it'll be a CT scan as well. So that's the full list of information that we will need in order to plan our case properly. So the first part is mounted study casts. And from this aspect, they need to be mounted. And they need to be mounted in a decent articulator. And what we're looking for on our mounted study casts is, as you can see on the screen here, occlusally, we need to look at the retruded contact position and the intercuspal position and the slide between the two. Just because you're doing aesthetic dentistry, do not think you can forget the occlusal principles. We have to understand those occlusal principles and use them day in, day out if we want predictability with our restorative and our aesthetic dentistry. So our models will need to be taken using a face bow and put on a decent articulator. We'll talk a little bit about that in a minute. But what we're looking for on the articulator is the slide from RCP to ICP. That has such a bearing on the way in which I'm going to work. Am I going to work in a reorganized manner, do an occlusal adjustment and make RCP and ICP the same? Or am I going to work around ICP in a conformative approach? We need to be looking at the discrepancies in the occlusal plane. We'll talk a little bit later about occlusal planes. Occlusal planes hugely important for the longevity of your restorations. What we need to do is we need to make sure that our masticatory system is working A, in harmony, and B, under the least amount of stress. Now, if we can have very flat, even occlusal planes, that means that we don't have to have very steep guidance. That means we have shallow guidance. Shallow guidance means that the masticatory system then works under its least amount of stress. We need to look at the amount of wear on the teeth, the wear facets. We need to be able to look at how the mandible moves and how it creates those wear facets. Because if there's a wear facet there, and we'll see later in several cases, and you restore that wear facet on that, let's say it's an anterior tooth, to its ideal shape and form, then that restoration is going to have the same forces on it unless you do something to the occlusion. And that can lead to that restoration failing, especially if it's in the crossover position. We need to look at the size of the edentulous spaces so we can decide if this is going to be implants, this is going to be bridge work, it's going to be partial dentures, maybe a stable base denture. The amount of crown height available. Are we going to have to do some crown lengthening in order to get enough resistance retention form for our restoration? This is a very important one. I'd probably say on the list, the most important, the anterior tooth relationships. Every single restoration or every single mouth that you're treating, if you want to reduce the stresses in the masticatory system, if that means then reducing the stresses on your restorations, then you have to provide them with good anterior guidance. Good anterior guidance discludes the posterior teeth. Good anterior guidance is class 3 leverage, not class 2 leverage. And in order to have good anterior guidance, we have to have anterior teeth in contact. We cannot have anterior guidance if our anterior teeth are not in contact. So you are going to find some situations where once you've mounted the study cast, you've done your occlusal examination, you've got some very, very strange occlusions that might be developmental. It may be as a result of somebody who's done restorative work in the past. And you have to go and find a way to get the anterior teeth together so that you can create guidance, so you can protect your restorations. And as we've mentioned, the relationship of the teeth during excursive movements. So we need to take some occlusal records in order to mount our study casts. The first occlusal record we're going to take is, of course, our face bow. And here you can see some slides of a traditional Dana face bow. What we need to understand with face bows is the accuracy. It is not a panacea. Just because you're taking a face bow does not mean to say that all of your work now is going to be super accurate. Okay, a face bow has its drawbacks. It is only 75% accurate to within 5 millimeters of the point that we're trying to find. The point we're trying to find is the terminal hinge axis, that imaginary line through the centers of rotation of both condyles. The face bow gets there within a 5 millimeter radius, okay, 75% of the time. So 75% of the time, if you do everything else right, then your face bow will give you a good degree of accuracy. 25% of the time, then you may be disappointed in the occlusal accuracy. It will still be more accurate than if you didn't take a face bow and just use handheld casts. However, you will need to do a reasonable amount of adjustment. So that's 1 in 4 cases. I'm often asked, if I'm going to do a crown, a bridge, or whatever, in which situation to take a face bow? The answer is time out. We take a face bow every single time. If the restoration that I'm going to be doing, okay, the tooth I'm restoring, if it's going to have an occlusal contact, a relationship with the opposing tooth, then my face bow will give me greater accuracy. And that means, remember, that means that we have less time, we require less time to do the restoration. Less time, time equals money, and therefore we can be more profitable. So as well as being accurate, we can be more profitable if we use the face bow. The face bow can also give the horizontal line that we're talking, that we need to talk to our technician about. The horizontal lines that we talk about are either interpupillary line or intercommissure line. Okay, we will be, when we do anterior restorative and aesthetic work, working to either the interpupillary or intercommissure line. And that means we have to get our anterior occlusal plane, the incisal edges of our teeth that we're restoring, parallel to one of those lines. We also have to make sure that the center line between those teeth that we're restoring is now perpendicular to the anterior occlusal plane. We can do that many ways. We can do that with the Cois facial analyzer. We can do it with the face bow. We can do it with the stick bite. So there's many ways of doing it. I will use it with the face bow very often. And what I'm doing here is I've got interpupillary line, as you can see. I've got now the line parallel to the interpupillary line, and you can see that my face bow, top part of my face bow, is not parallel to that line. So I'd need to just move that face bow ever so slightly so that I can get the top part of the face bow parallel to the interpupillary line. And that way, I would then transfer that interpupillary line to the articulator. Remember, when the technician mounts his models in the articulator, the top part of the face bow is mounted so it is parallel to the top part of the articulator. So when the technician is making his incisal edges of his restorations. Okay, the top part of the articulator is his horizontal line, is his reference. Another way, and especially one where we want to take a reading, if you like, of the intercommissure line, is the stick bite. And here you can see the stick bite in use. And the stick bite is a simple silicone bite, which we use, and then we put a little stick. This can be any form of horizontal stick. It could be a lollipop stick. It could be a little acid etched plastic brush, something like that. And we ask our patient to smile. And then we move that stick so it goes through an imaginary line between the commissures. That way we can get the correct horizontal plane. We need to do a jaw registration, and our typical jaw registration is a bimanual manipulation or a chin point guidance around RAP. Remember, we're mounting our study casts in and around RAP. We can then decide to work around RCP, or we can unlatch the articulator, move the models into ICP and work around ICP. It doesn't really matter at that stage. We have the ability to do both. If we have muscles that are very, very tense, then we can deprogram first. And there's multiple ways of doing that jaw registration, including leaf gauges, including little jigs, etc. All we're doing here is getting the muscles relaxed so we can take a good registration. We have to think about articulator selection. And remember, guys, this is not an articulator. Just because your technicians glued a piece of plastic with a hinge onto the back of the models, that bears no resemblance of the way that the mandible opens and closes. And therefore, because of the distance and the positioning of that hinge, the lower teeth will hit the upper teeth at an angle, which bears no resemblance to how it is in the mouth. If the more it bears no resemblance, the worse it is, then the more occlusal adjustment you have to do. So in effect, what we're trying to do when we're trying to find that point with the face bone, we're actually trying to find the angle at which the lower tooth hits the upper tooth, because we're on a hinge. If we get that angle correct, then that means minimal adjustment. If we're a long way out, as in this radius of closure here, the condyle would be up there somewhere. So that radius of closure bears no resemblance to what's happening in the mouth. There'll be a lot more adjustment to do. So we've got two realistic articulators that we can be working with, depending on what the brand is. Then we've got the semi-adjustable and we've got the fully adjustable. With the semi-adjustable, here's our Danar semi-adjustable. It's adjustable in 3 different settings. Okay, so that means that condyle inclination is adjustable, immediate side shift is adjustable, and progressive side shift is adjustable. And we can use this articulator in 3 different ways. We can use it with preset settings. So it is adjustable, you can set it to what you want. And the settings that you've got on the screen there are deliberately set to give you negative values. Now, what we mean by negative values is not making sure that the teeth don't contact when you tap up and down. Negative values on this articulator with these settings means that as you move your jaw from side to side, the cusps are not tall enough to create a non-working side or balancing side contact. So these settings will always give you fairly shallow cuspal angles, which will disclude very easily. So these are settings that are easy for you to fit the restoration, and you can be relatively sure that you won't get balancing side or non-working side interferences. However, they will not look as aesthetic as they could be, because the tooth next to it, let's just say we're doing a molar crown on a 6, the 5 in front and the 7 behind have got steep cusps, and then your restoration's got shallow cusps. So it doesn't look great. It looks like a crown, not like a tooth. Now we can change that and we can actually put it to average values. Okay, we know from population studies what our average values are. Now, if we set it to average values, 50% of the time, we're going to get probably cusp angles that are too steep, which means that from side to side, we will get some rubbing, or the teeth will not disglued quickly enough. 50% of the time, we'll still get flatter occlusal surfaces. but the flatter occlusal surfaces will still be steeper than they were with the negative values. So what this means with the average values, you're going to get a better looking crown with steeper cusps, but 50% of the time you may have to do some adjustment for lateral movements. Third way in which we can use them is we can customize. And now by customizing, hopefully we'll get the steepest cusp angles we can do, but they will still miss each other as we go from side to side. So those are the three ways. And for that, we'll use a check bite and we use a protrusive check bite. We don't use lateral check bites because the semi-adjustable isn't accurate enough to take lateral check bites. If we want to go to lateral check bites and take those and get a greater degree of accuracy, remember, greater degree of accuracy means two things for you. It means steeper cusps so that the restorations look better, and it also means quicker time to go and fit the restorations. So if we're using a fully adjustable, we can program the fully adjustable with the lateral check bites, or with a Cadillacs, or with a pantograph. And one of the major advantages of the fully adjustable is that we can change now intercondylar distance as well. So our mounted study cast. Our second part is our diagnostic waxing. And my advice to you is you do a diagnostic wax up of every single case you're doing. Maybe you can get away with it with a single crown. However, the bigger the case, the more difficult it is for you to understand what the final restoration will look like. It's more difficult for the patient to understand what that final restoration is going to look like. And if you both don't understand what it looks like, throw in the technician who may not understand, then that's the time when we have problems with consent, negligence, and patients not liking the final restoration because they didn't realize it was going to look like this. So, simple case, Maryland Bridge, we're fitting from canine to canine, large chunk of soft tissue missing. I wanted to show the patient on the wax up that we're going to have to use some pink porcelain here, some ceramic. It's a reminder to me as well. So when it comes back with the technician putting in the pink wax here, the patient knows that he's going to have pink ceramic. So whether it's a small case, whether it's a large case, we still have to go through exactly the same criteria. So let's take you through a case, and this gentleman's called Ivor. If we look at his teeth, he's got a very, very worn dentition, and we're going to restore him. We're going to do a full mouth reconstruction. We mount our study casts. We'll also look and see what vertical dimension we're going to work at. In this case, I'm going to increase vertical dimension by approximately 5 millimeters to give him better facial aesthetics. And if we do increase vertical dimension, we now come back from our waxed up talking about occlusal planes, as we talked about earlier. Are there any disruptions to the occlusal planes? Flat occlusal planes create better harmony in the masticatory system than uneven occlusal planes. So we have to go and start to wax up to the correct occlusal plane first of all. So the answer is, what are our occlusal planes? The ones you know about: curve of Spey, curve of Wilson, curve of Monson. Okay, they all occur on the lower jaw. So when we're doing our initial waxing, we wax up the lower jaw first of all, we wax up the upper jaw afterwards. So it's always lower first. And to find that correct occlusal plane, we go to the retromolar pads. And the two reference points for the posterior reference points are around about half to 2/3 of the way up the retromolar pads. And we go to the lower because the retromolar pads are the only non-tooth parts where the occlusal plane goes through. And if we're doing with full dentures, for instance, we've got no teeth. If we're restoring a worn dentition, then the teeth have worn down. They're not in the correct position or shape that they used to be in. So we have to go and create a new occlusal plane. If I'm increasing vertical dimension, I'm creating a new occlusal plane. And I want to get that occlusal plane in harmony. And the only places that it goes through that are not dependent upon teeth are the retromolar pads. I then need to go to the anterior and create my anterior reference point. Now that's usually about 1 to 2 millimeters, the incisal edge above the lower lip, but that can vary very much with age. So those are my two posterior reference points. And now for my anterior reference point, I'm going to go and produce 1 to 2 millimeters of lower tooth above the lips when the lips are in repose. The way to get your lips into repose, go Okay, so how do I do that? For this gentleman, for Ivor, I take a perio probe. I probe behind the lip. I find out where one lower central incisor is. Okay, just one. In this case, I'm going to work with the lower left central incisor. I probe down behind the lip, and let's just say, for instance, that my lower central incisor is here, 2 millimeters below the lower lip. Okay, so I go 2 millimeters, and then I'm going to add 1 to 2 millimeters on top of that, depending on age. Maybe if the patient's a bit older, I'll add a little bit more on. So let's just say I'm going to add on 1 millimeter. So I want my lower incisor with the lips at rest to be 1 millimeter above the lower lip. Okay, so I'm going to say to my technician in a few minutes, wax up the lower left central incisor 3 millimeters taller. That will then give you my anterior reference point. So this is where my anterior reference point is going to be. Okay, so let's go back to our mounted study casts. We've decided that we're increasing vertical dimension by approximately 5 millimeters to give us space to do our restorations. Okay, look at this now. We've got space between the posterior teeth to do our restorations. So that will minimize the amount of destruction on the occlusal surface or incisal edges. And we're also going to improve his facial appearance. So what I've done now is just slip a little elastic band around the models on the articulator. We can move the elastic band up and down at the front and the back. So from the side, it can go, as you look from the side, it goes 3 millimeters above the lower left central incisor, and it approximately goes through the retromolar pads, 1/2 to 2/3 of the way up. I can now see approximately where my new occlusal plane is going to be. I then put a pencil mark where the rubber band was, so I can take the rubber band off. I now grind down the upper teeth. Now, this does not mean this is the amount of reduction I'm going to do on the upper teeth. No, I'm just giving my technician now space to do his wax up. Now, at the moment, all we've looked at is 3 points which have been connected with a flat plane. Okay, we know that the curve of Spey has a curve. So we're going to introduce a curve as opposed to a flat plane here. And we use a Boyle's plane analyzer for this. Simple piece of plastic. Your denture technician should have them. So please ask your denture technician. And this simple piece of plastic has built into it the curve of Wilson and the curve of Spey, the anatomical average curve of Wilson and curve of Spey. So what do we do? I ask my technician, wax up lower left central incisor 3 millimeters taller. I put the Boyle's plane analyzer on the 3 reference points. So it balances on that tall central incisor now that's 3 millimeters taller. It balances on 2/3 of the way up the retromolar pads. And now I say my technician waxes up the rest of the lower dentition so it touches the undersurface of the Boyle's plane analyzer. And this way I can guarantee that I get my ideal curve of Spey. Okay, again, anatomical average curve of Spey, radius of 4.5 inches. And I also get my curve of Wilson. Curve of Wilson, remember, buccolingual. Buccal cusp of molar, lingual cusp of molar, lingual cusp of molar, buccal cusp of molar. Again, that's a curve. So I've completed my lower wax up. I'm now going to go and do my upper wax up. We do exactly the same thing. Let's just say for Ivor that I want him to show 1 millimeter of upper tooth when his lips are at rest. Okay, so I'm going to do the same thing. Probe underneath the lip. Let's just say the central incisor is 1 millimeter below it. And then I'm going to add 1 millimeter on. Again, depends upon age. Okay, we'll look at tooth reveal a little bit later on, and we'll show you how it changes with age. That's going to be our reference. So we say to our technician, wax up upper central incisor 2 millimeters longer. Now wax up other central incisor so it's the same length. Now wax up both laterals so they are just shorter than the centrals. Now wax up both canines so they're the same length as the centrals. I've now got my upper incisors all waxed up. Next thing to do is wax the palatal parts, so the palatal parts come down and touch the lower incisor waxing. Our final part is now to wax up the posteriors and bring them down. And that's then our final diagnostic wax up completed. And we go through that every single time. If you want to have predictability, you want to do this well so you get success every single time, you minimize the times that you have to go back and do something again, you minimize the amount of time it's going to take you to do a large restorative case, then we do it this way. And this means that my reconstruction can go pretty well. I can give Ivor a nice new smile, and this is Ivor now before and after. So that's our diagnostic wax up. Hugely important, one of the most important aspects. That is doing your full mouth reconstruction in wax, first of all. We then duplicate that into our prototypes. So our prototypes are exactly the same shapes. Okay, they are shell prototypes made by our technician, exactly the same shape. And what we do for a large restorative case like this, I have my prototypes, so they're made in 3 pieces. So the anterior part is splinted, anterior 3 to 3 splinted crowns, posterior splinted, posterior splinted. Anterior 3 to 3 splinted, posterior splinted, posterior splinted. And we now prepare the teeth initially, okay, and we put our prototypes on. And we know from the studies that we can change soft tissue levels correctly or incorrectly to make the case look better or worse by changing the sub-emergence profile. So it's a really, really important part. So let's look at a case like this. Already you can see we've got problems with the occlusal plane. It sort of goes down and then comes up, and it goes across and then it goes up again. So we have occlusal plane problems here, which we're going to solve. We will solve that in our wax up. We do our wax up. There's our occlusal plane, our nice flat, even occlusal plane. We've done the lower. First of all, if we're going to do the lower, if we're going to keep the lower as it is, then we just do the upper. We get our prototypes, again, exact copy of our diagnostic wax up. And then we go in and we start preparing the teeth. So these teeth already had crowns on, so we've taken the crowns off, we've prepared them, and now we start to do our reline. So we take our prototypes, we reline them, and we get them so they're then ready to be fitted in the mouth. And this is one of the important parts. So let's just take some time out here and remember what we're doing. Our technician has guessed at the margins. So you cannot just go and cement those prototypes in place. They won't be right. You have to reline them. And you can see here very easily where the margin was and where my reline is. You can see my reline with a flowable composite. Luxatemp is what I use, a DMG product, Luxatemp. You can see it's more translucent, and you can see easily where my reline material is. And what we're going to do now is we reline, and then we can start to change the sub-emergence profile. And we know that our sub-emergence profile comes out at around about 30 degrees. If we make our sub-emergence profile less than that, soft tissue will fall down the crown. So we'll get what looks like more gingiva growing down. Likewise, if we take our 30 degree and we make it 45, 60, or even more, then the soft tissue will start to recede because it has pressure on it. So we can play around until we get exactly the right soft tissue. And here we are playing around our first attempt to get the soft tissue to come down to the areas that we want them to be in. Hugely important, okay? At the same time, we also have our preparation guides. And our preparation guide is a simple pull down, suck down, okay, like a bleaching tray if you like, but a little bit harder, more rigid, thinner, harder, more rigid than a bleaching tray, a little bit more like an Essex retainer that is pulled down either over the top of the prototypes or over the top of the diagnostic wax up. And this now will guide us in the correct amount of tooth preparation. So here's a case where we're going to do some anterior crown work and improve the aesthetics. We can see there's some problems there. Our diagnostic wax up is completed. Our prototypes are done. The suck down is now over the top of the prototypes. We start to prepare the teeth. We've got to prepare the teeth a little bit first of all until the preparation guide can seat in the mouth. Once it's seated, we can now drill little holes in that my perio probe can pass through, and you can put 5, 10, 15, 20 holes into this. So you can probe through in all different areas to make sure you have the correct amount of space. Correct amount of space for your restorative material. We then put our prototypes on, and we can then duplicate those in the final restoration. So everything has a certain protocol that we follow. Follow the protocol, get predictability. And finally, in this part, cosmetic imaging. Again, hugely important part. The diagnostic wax-up will give you some aspects of aesthetics, but it also gives you function. The other area where we need to look at is aesthetics. And the only way that our patient can understand what the final result's going to look like is if we give them an image of what their smile looks like. And this is cosmetic imaging. Here's a lady, Julie Peasgood. She's an actress, television personality. As you can see, she's got many problems here. Thin lips, too much soft tissue one side, not enough the other side, abrasion, lesions, what look like very, very large lateral incisors, which are in fact canines that have been crowned to look like lateral incisors, soft tissue inflammation here, anterior occlusal plane not parallel to the eyes, whole host. And we can do a very, very detailed treatment plan to her. Say we're going to do this, we're going to do that, crown lengthening, connective tissue grafting, etc. Very often doesn't mean a lot to our patient. However, if we do an image, and this is with the proviso that you understand enough about treatment planning, aesthetic dentistry, occlusion, tooth preparation, and have a good technician, if you understand those 5 things, then that means that you should be able to be in a position to give your patient this end result. And of course, when the patient sees the end result, the patient naturally goes, wow, I love this, you can really do this for me. Okay? They now need to have that work done. It's not just a matter of, oh, should I have it done or not? They see the end result, it creates need. So cosmetic imaging is a hugely powerful, okay, sales tool. And I use a lady called Tracy Rook. She has a company called Smile Imaging. And we've already done a webinar with her on smile imaging, cosmetic imaging, during the lockdown. If you want to see more, go and take a look at that webinar. So let's look at a case. Now, this is also a case where not only can we show the patient the end result and work to it, and we can sell the end results to the patient, but it's also an important part of the treatment planning process. So let's just look at this lady. What do you see from this lady? You see a very, very attractive lady in her 40s, a little bit more closely at the smile. That doesn't look very nice. A little bit more closely, she's got an awful smile. And we've got problems with a bridge one side and no bridge the other side. So in effect, she's got one extra tooth here. Okay, and when we look at smile design, obviously one of the major factors is symmetry. We have symmetry right and left-hand side. Here we have no symmetry whatsoever. We have a lateral incisor one side, we have the lateral incisor space closed up. So part of my treatment planning now is going to be, what shall I do about this? Automatically, I have 2 options. Okay, first option is to try to take that lateral incisor pontic away, move the central incisor back into the correct position, and then try to make both of those canines look like lateral incisors. So create symmetry. My problem is now the teeth are going to end up being pretty wide because I'm taking that space out and I'm making the rest of the teeth fill the space. So I'm going to end up with symmetry but wide teeth. Second option is to go and put an extra tooth in here. So to do some tooth preparation and maybe do a little bridge here whereby my pontic goes in. I'll replace that bridge obviously, but now I'm going to have symmetry. 2 3-unit bridges at the front of the mouth, or a couple of single crowns and 2 cantilever bridges, lateral off canines, something like that, but again, symmetry. Now my teeth are going to be ending up a lot thinner because I've somehow got to get a tooth into there. So do I go with symmetry and wider teeth or symmetry and thinner teeth? Which one's going to look the best? Well, this is where we do our cosmetic imaging. And it's not me, it will be the patient who decides. So the first instance is we've got symmetry and we've got wider teeth. Those lateral incisors are pretty wide. Second one we go for is symmetry with thinner teeth. Okay, so all the teeth now are much, much thinner. I added in a third option, which would be to flip the bridge over. So we have the bridge here, thinner teeth one side, fatter teeth the other side, just as an alternative. We have to give all our alternatives. Fourth alternative, of course, would be orthodontics, long-term orthodontics. But with the amount of restorative dentistry she had previously, she was happy to say, no, I just want a restorative result. I'm not going to have any orthodontics done at this stage. So again, the question to you is, which do you think is the best result? Which would you choose? If you had to choose, which would you choose? Well, our patient, in fact, chose the smaller teeth. And that was the final result. With the smaller teeth, we managed to get some bridge work into this area. We didn't take any teeth out. We didn't devitalize any teeth. This is a mixture of creating an illusion and also physically putting the teeth back there. But that result would not have been possible, and the patient, we would not have gained consent unless the patient could see what the different teeth and smiles would look like. And there's our final smile with Our Lady. And again, just to re-emphasize our second case here, we have a gentleman with a big gap between his teeth. He wants the gap closing, or he's unsure about closing the gap, but he wants better looking teeth. So we've done some imaging, keeping the gap the same, closing the gap by 3/4, closing it by a half, and closing it completely. So our patient again can see, can mull over, him, his wife, his family, whatever, friends, can look and say which one he wants. Okay? He ended up saying that he wanted this one. He wanted to keep a small gap, but get the gap so it was smaller. So this is where we started. This is his chosen restoration, and there's his final smile. Now again, I'll just re-emphasize why this is so important. From a consent issue, of course, it's important. Secondly, from a tooth preparation point of view, if I'm going to close that gap completely here, I have to do very heavy preparation on the distal aspects of those centrals. Okay, so I've got space to move the laterals mesially into the space occupied by the centrals. If I'm going to do just create or maintain that same space, it's going to be just a standard tooth preparation. So I need to know my tooth preparation before I go and start, because otherwise I'll be drilling the teeth down too excessively. So that's our diagnostics that we need to understand before we can then start to move on and design the smile. So now we're going to be looking at smile design. First of all, a couple of books, very good books that will give you some good information on smile design. I like this one by Goldstein, The Best, Change Your Smile. Also excellent for giving to your patients, so the patients can understand what smiles or smile design, what cosmetic dentistry can now offer them. So let's just take a beautiful looking face and try to understand what makes us look at this face and also the smile and say it looks pretty, it looks beautiful, it looks handsome. As we've mentioned already, one word, symmetry. So we need to have symmetry across the midline. The more symmetrical it is, the more false it's going to look. The less symmetrical, the more natural. And what we've got to do as dentists is create that balance. Some patients want pure symmetry. They want the ideal smile, the media smile. Other patients want an improvement. That's down to us to talk to the patient to understand what they really want. We'll show you both smiles as we go along. The second part is the occlusal plane. We need to have the anterior occlusal plane. We've talked about that already. That anterior occlusal plane needs to be either parallel to the interpupillary line or parallel to the intercommissure line. Now, in most patients, those two lines are parallel in any case, but always look, because in some patients, so you'll see later, they are different. And if you always work to the interpupillary line, it means that if we get an intercommissure line, which is canted, when the patient smiles, they'll show more tooth one side, less tooth the other side. And that can be a really, really poor aesthetic result. And we also need to make sure, just one more thing going back, that these lines cross at 90 degrees. There is no canting at all. That's very, very visible. And the third thing that we need, facial proportions. We see that there are various facial proportions we can work to. Two big ones are golden proportion, where hairline to base of nose to chin is in the golden proportion, 1.6 to 1. The other one we can work to is facial proportions, where we look at thirds. So we have the hairline to bridge of nose to base of nose to chin being equal thirds. And that's where the vertical dimension comes in. Remember, we own this lower third of the face. We can increase vertical dimension whenever we wish to. So remember, when you are doing a cosmetic makeover involving veneers or crowns or whatever, you have the ability to increase vertical dimension, which will make the face look thinner, will make the face look more in proportion. Okay? A thinner face, a more in proportion face, we know from scientific studies, looks younger. What number of your patients, if you gave them the ability to say, I can also make you look 5 to 10 years younger as we do this smile facially, how many of those patients would say, yes, please? And you can be the dentist that not only makes nice smiles, but also makes nice faces. So we have two smiles. Just like in restorative dentistry, we choose between reorganized and conformative. In aesthetic dentistry, from an aesthetic standpoint only, okay, we'll still make that same decision when we're doing aesthetic dentistry, reorganized versus conformative, because it is restorative as well as aesthetic. But from a purely aesthetic point of view, we have media smile versus natural smile. And that's something that we have to get through very, very early in our conversations with our patients. So the media smile, what is it? The media smile is characterized by long contact areas, by overly white teeth, by symmetry, right and left hand sides, absolute symmetry, by minimum incisal embrasure, gingival embrasures. And this is characterized by many, many people in the media, hence the media smile. And they have their teeth done, and their teeth are overly white and symmetrical. And one has to say these days, which looks worse, the hair or the teeth? And we then have the natural smile. And the natural smile is much more difficult to achieve. The natural smile is one where you're creating a balance. You're using your artistic side, working with the patient. You've got the media smile, which is black and white. It's either media or it's not. So symmetry is black and white. It's symmetrical or it's not symmetrical. Now, with a natural smile, we're creating a non-symmetrical result, but it's shades of gray. How unsymmetrical. So look at the words. We're looking at words which are softer, got various meanings. Pleasing balance, idealism and diversity, subtle way, asymmetrical, symmetry, black and white, asymmetrical, many shades of gray. So this takes a lot more work. And then we have that bit in the middle where our patient says, I don't want it to look false. I want it to look natural, but I also want it to look very beautiful. Okay, and for those, when we've got something that we can look at here called shade progression. So for those people who want to be in the middle, I'll look and say two things. We can do two different sorts of smile. Okay, we can make the teeth overly white. Okay, so say I'm doing some veneers or I'm doing some crown work, and I want to give the illusion that these are natural, beautiful teeth, not a media smile where people say, I love your crowns, I love your veneers. No, we want to make these look natural so people say, you've got a lovely smile. So how can I do that? We can have two setups. First of all, we can have a very even setup, totally symmetrical or very close to it, and then introduce different colors, shade progression. That's number one. Talk about that in a second. The second way, for those people who want absolutely white teeth, is to create the absolutely white teeth, but have more asymmetry right and left hand side. Almost as though they could do with just a little bit of orthodontics, but they've had their teeth whitened. So we rotate a lateral incisor. We make the inclination of two canines slightly different, the premolars slightly different. Centrals are always the same though. So those are our two ways. So let's look at this, and we can see this comes out in the natural dentition. Okay, we look at three smiles here, and these are photos from a magazine. So I'm sorry they don't look as good, but you may just see a hint that that canine is darker than the lateral. You'll see another picture of Jennifer Aniston in a second. Kate Winslet, the canine's darker than her anterior teeth. Okay, and again, now we can look at Friends star, Jennifer Aniston, that the canine is darker. So one of the ways in which you can make a symmetrical smile look more natural is shade progression. Shade progression is two things. Shade progression is front to back. Shade progression is also gingival to incisal. And remember that natural teeth are not all the same color. Natural teeth start off at the gingival margin, a sort of a yellowy, browny, orangey color as it just comes out. We then go to something like a light yellow. It then goes cream. It then goes white. It then goes gray or blue as we work our way up. That's the natural color coming through. So we can create that with the natural tooth, shade progression, gingival to incisal. And we can also do it front to back. And we do it front to back by changing the color slightly. So the central is A1, lateral is 1.5, canine's A3, premolar is A2. Now, as soon as you go and get a shade tab and say to a patient, okay, there's your shade color, that's A3, the patient's first response is going to be, that is too dark. So of course we can do subtle changes. We can make the centrals and the laterals A1. We can make the canines A2 just a little bit darker. We can make the premolars A1.5. We could do A1 for them all, but have the gingival half of the canine shade A2 or A3. So we can work around it, but it's one way of giving a better smile. So we looked at media versus natural. Now let's look at some of the more specific parts. Let's look at centerline. What do we know about centerline? Centerline should be related to a specific facial landmark. The center of the upper lip is the ideal one. What else do we know? There's just over a 50% chance that if you've got the centerline, so it's not in the middle of the upper lip, that there's a 50% chance that a lot of other people, including your patient, will not notice it. So always, we'd like to go and get the centerline ideal. So look at Tom Cruise, okay? Now we look at Tom Cruise, handsome guy, but from a smile point of view, center line of his face, red line, center line of his upper lip, black line. Which one do we choose? Always go to the center line of the closest anatomical landmark, which is the upper lip, okay? Because that's where we see a smile frame. When I look at somebody, look at the smile, I can't see the eyes, I can't see the hair. What I can do is I can see the lip and the teeth in the same instance. What is more important than center line, more important is the verticality of the center line. So more important than getting it mesiodistally correct is to get it so that it is at 90 degrees to the incisal edges, the verticality. So let's look at a case. So this lady refused orthodontics. She's a hairdresser. She's got a midline shift, as you can see, and we want to try to improve that midline. Now let's show you some of the downsides. Now, if we can choose orthodontics, that is our gold standard, absolutely gold standard, okay? And we can overcome some of the problems. She has said no to orthodontics. So we look very closely. She's got a very, very uneven smile. imbricated upper arch. We've taken some impressions for some mounted study casts. And here's our mounted study cast showing you more in detail of where the lateral compared to the canine, to the central is. And we've got a center line shift of, in this case, about 2 to 3 millimeters. We've done our diagnostic wax up. Now with our diagnostic wax up, we have made the center line so it's in the ideal position. But look what happens with the diagnostic wax up. Straight away, the zeniths have changed. It's important you understand the relationship between zeniths of teeth and center line. Change center line by restorations, then you change the zenith. What we then have to do to get that zenith to look better again is either gingival surgery or changing the sub-emergence profile. Again, with our prototypes, we can see the zeniths are just wrong. The zenith to a central incisor should be to the distal, okay? That center line is bang in the middle. That center line's too much to the distal. And again, here's our initial wax up. We've got a nice even result. Our prototypes, a lovely even result. We prepare the teeth. We put the prototypes in, and of course, it's more visible now that the zeniths are in the wrong position. So we have alternatives. First alternative is go back and change the center line and put it back to where it was. So zeniths are fine. Second is leave it like this with the center line correct and the zeniths not ideal. Third is do a little bit of both. So improve the center line so it's not ideal, but it's within 2 millimeters, and try to get the zeniths so the zeniths do not look too bad. Fourth way is go for perfection, which involves further gingival surgery or playing around with the prototypes and the sub-emergence profile for a long period of time. Out of those, my patient wanted the compromised result, where the center line is better and the zeniths, so she didn't really understand zeniths when we're talking about them in any case. So here we've created our ideal center line. Look at that. Center of the upper lip, center line looking beautiful, but zeniths not good. So we now go back. We've gone back somewhere halfway between the ideal and where we were originally with our final restorations. And these are just some ceramic porcelain veneers, and we've cemented these in place. And you'll see in a second where we've come from. So this was our original center line. Look at it in relationship to the lower tooth, which are not touched. We now went from here to here, and we've now come back again just a little bit. So we're now in the center of the tooth. We're somewhere between the distal of the incisor, the mesial of the incisor, back into the center. And from here, we've now gone to there. And we've got a better smile. It's not ideal. It's a compromise, but a lot of the restorative dentistry we do without orthodontics is a compromise. But our patient, absolutely delighted, wanted a media smile, wanted overly white, even teeth, and that's what she's got. Incisal plane. So what about the incisal plane? Incisal plane should be parallel to the either lip line or eye line, and we should have a nice convexity to it, which mirrors and follows the lower lip. Okay, and here we have a desperate housewife from the series, and we've got a nice anterior occlusal plane, looks in harmony, and a very, very beautiful looking smile. Now, as I mentioned before, we are going to have some patients whose eye line and their intercommissure line are not the same. Okay, you initially look at this patient, and on the slide on the left-hand side, she's a model. She's a lipstick model. She appears in adverts. You would not look and say she's unattractive. However, when we look closely, this is what we can see. We can see that the interpupillary line, the black line, and the blue line, the incisal edges of her natural teeth, are not parallel to each other. And we can see, in fact, that the blue line here and the green line, the intercommissure line, are parallel. So in fact, for her, she has the ideal smile. And if you can imagine now, if you changed the anterior occlusal plane so that it was parallel to the eyes, then your anterior occlusal plane would look like this. Less tooth showing here, much more tooth showing there. And remember, when we look at somebody's smile, all we do is see this part. Okay? We don't look at somebody, look down, look up, look down, look up, and try and make sure that the eyes and the lips are the same. That is not social etiquette. So again, how do we do that? We mentioned already, face bow parallel to the eyes or a stick bite. And we can transfer that information to our technician. And here we have a case where our anterior occlusal plane with some horrible old crowns is incorrect. And the first thing you're going to be looking at is, of course, changing the crowns. However, what else is the problem here? We have a bigger problem. Our bigger problem, because we can change the crowns easily, they need restoring. Our bigger problem is the two canines, because they're on the same occlusal plane. We want to produce a flat occlusal plane like this. So it's the two canines are a problem. Our premolars are problems. And as we get further in the back, our molars may be a slight problem. Obviously, the further back in the mouth we go, the occlusal plane problems get less and less. But if we produce an anterior occlusal plane, which is now parallel, let's say, to the top part of the slide, which it should be, that's where the eye line is, then we're either going to work off that canine and then have a great big step down to this canine, or we're going to work at that canine and then have a big step up to that canine. So we're going to do something with the canines and the premolars. Okay, and you can either decide to lengthen this canine or shorten that canine. We decided we would shorten the right canine. So we've done our diagnostic wax up. We've done our preparation guide. The technician has done his initial preparations on the model and produced prototype, shell prototypes, which I will reline in the mouth. We've now gone and done our tooth preparations. We're taking the old restorations off. I've shortened the canine as well, so the canines are now on the same level. I've changed the cores, and I've also, because this canine is now shorter than this one, I've done some crown lengthening on this canine, so the canines are now the same length. So this is a complex smile makeover. I'm also using the Dentist Tarnow study, and I'm making sure that I can have as shorter contact areas as possible, but also maintaining the fact that I have an interdental papilla. So I've bone sounded interproximally, given that information to my technician, whereabouts interdental bone is. We've taken our dual cord impression for some zirconia crowns, put my prototypes on, and now from here, we've gone to there, our final end result. And again, anterior occlusal plane parallel to the eyes, canines parallel to the eyes, premolars parallel to the eyes, laterals, centrals, everything parallel to the eyes. And at the same time, we've managed to get a little bit of infill. We had bone loss interproximally from those horrible crowns. We've got some little bit of downgrowth, and you can see where the old interdental papilla was deficient and the downgrowth I've got. The old interdental papilla and the downgrowth you've got, and not quite as much just there. But a nice aesthetic end result as a result of understanding occlusal planes. Next one is smile line, and our smile line is the amount of curvature that we have from front to back. So how much curvature is there in the front of the mouth? What do we know about it? We know young people and females have more curvature. That's the curvature I'm talking about, okay? So remember this, when you're doing a smile makeover for a younger person and a female, you're going to have more curvature. Likewise, the opposite. We go to a male, we go to an older person, they have a flatter anterior occlusal plane. Young person would have something that's coming down like this. Female, more like this. Older person, male, a flat, more aggressive look. So let's look at our patient. Let's produce one now for a male that's going to be a little bit more rugged and a little bit flatter. So this is what we do. So we have our patient here, our patient's aware case, and we'll go and look at his lips. His lips initially, you can see there's got no teeth in when he goes Emma, which is an indication he's lost vertical dimension. So we're going to be increasing his vertical dimension. This is his natural smile. This is his big smile, his yee smile. We've done some cosmetic imaging for him, so to show him what his new smile is going to look like, we can actually show he's got some teeth in there, which he's very comfortable about. He's a class 3 at the moment, but that's only because he's overclosed. As soon as we start to open him up, those lower incisors will drop backwards, they'll drop lingually, and that will allow us now, so this is him at the moment. When we open him up, those lower incisors will go backwards lingually, which will now allow us to lengthen the uppers and create a class 1 occlusion, which will give us anterior guidance, etc., etc. A little bit of whitening. We're now going to do our mounted study casts. There's our diagnostic wax up on our prototypes done. Again, anterior view, flattish, okay. If this is a female, we'd be coming down more to here. A younger patient, more to here. This is more or less flat across. Lateral canine tips, lateral centrals more or less on the same plane into our prototypes. We prepare the teeth, take the old restorations off, prepare the teeth, put our new prototypes in place. So we have now produced a very, very nice aesthetic result in relation to the lips. This is now his final smile with his prototypes. And of course, all we do now is transition this to the definitive crowns. And with the definitive crowns, we put a little bit more color into the gingival margins so that it reflects the color in the gingival margins of the lower. And we now have a beautiful looking end result, fairly flat occlusals. And of course, because he's a bruxist, we've also gone and put an occlusal splint in place. And there's our final smile and starting point imaging and final smile. So our incisal plane should be, as we've mentioned, round for young, flat for older. Now, if you get it wrong, it looks really ridiculous. Here is sadly departed lady, used to be on our screens an awful lot, Cilla Black, and she was well known for the fact that she had very large front teeth. And look at the fact that she's got a very, very curved smile line and how ludicrous that looks. So we are going to see some older patients or older ladies, and whilst we need to get that nice balance, we can't give them too much curvature, it looks ridiculous. But sometimes if they're overly flat, we need to give them a little bit of curvature, somewhere in between. This is where we talk about that pleasing balance that we need to try and acquire. So we have a lady here who's got very worn anterior teeth, got class 3 composites in place, done all of our diagnostic again, as we do with every single case. These are the composites that we've got in place. So we're going to do some veneers. We've done some 3/4 crown preparation style veneers for her. We've hybridized the dentine, taken our impressions. Prototypes are in place, so we're working with the prototypes to see if the teeth need to be a little bit longer, if she's quite happy with them. Then we copy the incisal edges using an incisal edge matrix, and we take our patient from flat incisal edges and what was a reverse smile line to something now with a little bit of curvature. So there's our anterior curvature. So for feldspatic ceramic veneers, we'll talk about the types of ceramic a little bit later on. I like feldspatic if I want to put color in place. So color for me comes from feldspatic. So I'll mention this case again a little bit later on. Beautiful, beautiful aesthetics, lovely color we've got in here, crack lines, translucency, etc., all coming from feldspatic porcelain. And our final end result. Contact areas, contact points. So we really don't call them contact points, call them contact areas. And contact areas, we have something straightforward called the 50-40-30 rule. But we have to balance that up with the Dennis Tarnow study as well. So ideally, if we look at a beautiful smile, so a model, a TV film person, Scarlett Johansson, actress, we look at a little bit more closely at a smile. What we're talking about is the contact area between two centrals. That contact area should be 50% of the length of a central. The contact area between central and lateral should be 40% of the length of the central. The contact between lateral and canine should be 30% of the length of the central. So we always go back to the length of the central. That will create a beautiful aesthetic result. Now, our problem comes if, as in one of the cases I showed a little bit earlier with the incisal plane, which was incorrect, and you've lost interdental bone, that if you do that, sometimes you'll have a missing interdental papilla and a black triangle. So sometimes you have to break those rules, okay, to make sure that you get a papilla as opposed to a black triangle. But if you don't have any bone loss, these are the rules. Golden proportion, we know what golden proportion is, and we can see with our eyes golden proportion. This does not look good, okay? Your eyes say that there's something wrong with this proportion. So golden proportion is something we see in nature, something that we look at and say, that looks beautiful. Now, it's come under a little bit of fire recently. Golden proportion tends to create teeth, laterals, canines, which may be a little bit on the thin side. And again, our smiles are getting bigger and bigger and wider. So we have other alternatives to it, but I still like to use it as my base, my initial wax up for golden proportion. And you know what it is, 1.6 to 1. So what it is, 1.6 to 1 to 0.6. And we can see this easily now on a drawing. Central should be 1.6, lateral 0.1, canine 0.6. Okay, now that's not the true width, remember. That is the perceived width that we see when we're looking in 2 dimensions from the front. Okay, so it's the perceived width, that's all we're seeing. And we can use golden proportion calipers, and the golden proportion calipers will tell us if the proportion is correct. And I ask you to go and suggest you go and get a set of golden proportion calipers. You can have them for the face, you can have them for the teeth. And you look at beautiful smiles, just to re-emphasize for yourself, confirm to yourself that yes, this is correct. Then you can see by using them on models' faces, beautiful faces and teeth, that the golden proportion actually does work. So here's a case. Here's a case where we've got a problem with proportion. Look straight away, and what do you see? You see that the canines are too big. Lateral width and canines probably about the same. Lateral a little bit too wide compared to central, so it's a golden proportion problem. We now take the lips away, and we also have a width to length ratio problem. So we have 2 things going on here now. The mesial to distal proportions wrong, the incisal to gingival proportions wrong. Incisal to gingival, the width to length ratio should be 75 to 80%. Front to back, golden proportion 1.6 to 1, 1.6 to 1, 1.6 to 1. So we're now going to have to go and change that. So what ways have we got to change in that? We've got physical ways. We can put the proportion exactly as we want it to be, but we've also got ways that we can disguise it. Okay, we've got ways we can disguise things, make it look slightly different. And these are ways of using color, using shape and using color. So if I want to make this tooth look shorter, okay, it's very long, make it look shorter, what do? I put more color in the gingival, more color in the incisal. If I want to make it look shorter, I put horizontal striations. Likewise, if you've got a very short tooth, very wide tooth, make it look thinner, you put longitudinal striations, you put stripes in place. So there's lots of things we can do. And at the moment, our width to length ratio is probably around about 50%. 50%, the width is 50% of the length. The length of a central to the width of 2 centrals should be in the golden proportion. You can see here it's not. So we're going to do our normal diagnostic work, prototypes, etc., preparation guides, and we'll prep the teeth. I'm going to go subgingival, and I'm now going to change the subemergence profile. I'm going to change the subemergence profile from 30 degrees to 0. So we're going to come out flat. That's just the area underneath. So that's from the margin of the preparation to the free gingival margin. Instead of that inclination being 30 degrees, it's going to be 0. What that will do is allow the soft tissue to fall down a little bit. So here's my final restorations. Okay, and you can see in the mouth, we've got nice colorism. We've got the soft tissue starting to come down. Look at that interdental papillae that's starting to reform. And from here, we've created this illusion. We've now got the correct golden proportion front to back. We've got the soft tissue which has come down. I've flattened the anterior occlusal plane slightly. Okay, I've made the teeth look wider by taking the marginal ridge and making the marginal ridge go further out. I make the tooth look wider by flattening the anterior part. Just the opposite, want to make the tooth look thinner, then have more convexity on the labial aspect. But now we've got the right proportion. We've almost got, okay, get that to come down just that little bit more. We're into 1 to 1.6, okay? But we're very, very close to our ideal proportion. Here's our golden proportion in terms of a percentage. So you can decide to talk about golden percentage. And 25 to 15 to 10 is the golden percentage, or our standard golden proportion. And then everything looks in harmony. Incisal length, okay? What about incisal length? How long should a central incisor be? Central incisor should be, on average, around about 10.5 to 11.5 millimeters, around about that 11. There's wide variations, as you can see on the screen. What tends to influence the length of the incisor and also the amount that you show of it is the lip. So the determinant in the amount of tooth that you're going to show is going to be the youth or the age of the patient. A younger patient will show more upper tooth, an older patient less. And that's because our facial musculature relaxes a little bit more, we lose the tone, and our upper lip becomes longer. Another part of this incisal length is the length and curvature of the upper lip. So if we have a short upper lip, we have a lip with a lot of curvature, we show a lot of vermilion border, then that tends to make the tooth look longer. So the question is, where should the incisal edge be? You're doing, let's just say, patients missing 2112, and you're now going to do a canine to canine bridge. Okay, you've got your canines there, but where are the incisors going to be? Okay, part of that will come from the age of the patient and the amount of curvature. We've talked about that. But have we got anything else that can help us with this? We certainly know that younger people show an awful lot more central incisor. A model, Linda Evangelista, modeling for Clarins here, showing probably half the tooth. And if the tooth on average is 10.5, 11.5, she's showing 5.5 millimeters of tooth. Another one. Claudia Schiffer, another model, probably showing just a little bit more than that, probably 6 millimeters of tooth. So it all depends on the lip. And look here, young patient, female, short upper lip. Let's go back again. Young patient, female, short upper lip. Lip very, very curved. Lip very, very curved. So our incisal edge needs to be positioned in the right aspect for the lips. The lips are the ones that are going to tell us where the incisal edge should be. Short upper lip comes with a younger patient, more central incisor showing. Longer upper lip, thinner upper lip, less incisor that's showing. This is our tooth reveal chart, which I mentioned to you a little bit earlier. Really important you understand this. Maybe take a screenshot if you like, an iPhone shot, but this shows you with age, what happens to the amount of upper tooth showing and what happens to the amount of lower tooth showing. So at the age of 30, look at this, almost 3.5 millimeters. So you go Emma, 3.5 millimeters upper tooth. As we get older, look what happens. We get to 40, we've lost almost 2 millimeters of upper tooth showing. And that's because our lips are dropping down. We get to 50, goes to 1. 0.5 millimeter, nothing then at the age of 70. Again, look at the amount of lower tooth. When we're in our 30s, just see the incisal edges. When we get all the way up to 70, we're showing 3 millimeters of incisal edge of the lower. So when we're talking about where the incisal edges should be in relationship to lips, you have to know this chart so that you can give the average. That's your starting point, your diagnostics of the average. So you can give the average to the patient. Patient then may decide they want them longer or shorter, but at least you're giving the average. And very much if you have a 60-year-old, they may want the smile of a 50-year-old. So you don't just automatically give the 60-year-old the 60-year-old amount of tooth showing. You may decide to give them the 50-year-old to make them look a little bit younger to go with the dental facelift. Incisal profile, okay? And in terms of profile, we've talked about where that incisal edge should be gingival to incisal. Where should it now be labial to palatal? Okay, give you a little tip here. As patients get older, we've mentioned these lips that get longer and thinner. As patients get older, and my average age of patient is probably, my typical patient is a female, probably in her 50s. Somewhere between 50 and 60 years of age is my typical patient. And most of them want an aesthetic makeover. And most of them also would like to look younger. One of the ways I can do that is the dental facelift. We've mentioned that. I do that on a regular basis for my patients. The second way we can do that is moving the anterior teeth slightly forwards. If we move the anterior teeth slightly forwards, what happens? Straight away, the lip shortens. The vermilion border increases. So these are subtle changes. I'm not talking about moving the anterior teeth forwards by 5 millimeters. Okay, we're talking about moving them maybe forwards by 1 millimeter. And these will be subtle changes that the lip will shorten a little bit, it will evert, and they'll have a better lip line. For smokers, those tiny little lines that you can get on the top lip, they will disappear slightly. So as well as increasing vertical dimension, the dental facelift will try and bring those anteriors forwards just a little bit. We have, however, the opportunity, if maybe we are missing anterior teeth, again, the 3 to 3 bridge, those pontics and the ridge may have resorbed. We now need to have the pontics further forwards. Okay, how far can we bring them forwards? The maximum we can bring them forward is that the incisal edges, from a phonetic point of view, let's go through it. Okay, the F or the V sign, B, okay, so that F or V, incisal edges now contact the inner vermilion border. So we cannot take the incisal edges any further forwards than the inner vermilion border of the lower lip. So again, let's show you a case. We have a lady of that certain age. She's 50. We'll look at her teeth in a minute. She's a pretty lady, nice hairstyle, nice bright eyes. Her teeth are letting her down. She's got worn teeth. She's had composites done here. She's got abfraction or abrasion lesions. She wants to have a makeover. So we're doing some minimally invasive veneer preparations on her. And we're now testing out. We brought those teeth forwards to try to give a better lip support. Okay, and we're just testing them to make sure that they are now, she can speak her words. Okay, she can say her V's and F's. And once we've got that, then we can take an impression. The technician can then make the final restorations with them further forward. We've brought out the side teeth. We just look again at where we've come from. Okay, so looks as though we're missing a tooth here, missing a tooth there, because they are palatally placed. So we brought those out to widen the smile as well as bring the smile forwards and give a nice new shine to them. And from here, we've gone to here. So we've got a little bit more curvature. Okay, remember, let's just go back again. One here. We've given her a little bit more curvature. She's very flat across here. Not too much, not the Scylla black teeth, but a little bit more curvature. So the lower lip is just contacting. And we've given her a beautiful, beautiful new smile. Okay, finally in smile design, and there's a lot more to it. Okay, For those of you that have been seeing some of my webinars on smile design, we did smile design over three-hour webinars. So there's a huge amount. We're just doing a snippet here of the very basics of smile design. So maxillary teeth. Okay, we need to understand what maxillary teeth look like if we're going to restore them. I see so many technicians who do not understand what maxillary teeth look like. Maxillary teeth have a more prominent distal lobe. We'll talk a little bit later, a few minutes time, of what maxillary lateral incisors look like. Maxillary anteriors, maxillary laterals do not look, sorry, maxillary centrals, maxillary laterals do not look the same. They are totally different shape, and we have to understand that. So first of all, mesiodistal diameter, okay, 8.4 to 9.3 millimeters. Width to length ratio, 75 to 80%. What we do now, however, is our centrals have to look symmetrical. They can only look asymmetrical to a tiny, tiny degree. Okay, they have to look symmetrical. So we have a case here where we've got a smile which does not look symmetrical. Our patient does not like the looks of her upper front teeth. You can see we've got erosion. You can see we've got inclination problems. That tooth's inclined and overlapping. We've got malformation here. So she would like 2 ceramic veneers. So we've done our preparation for 2 ceramic veneers. And again, we're going to be doing feldspatic porcelain here, so we can actually bring some color to the teeth. And we're going to make these ceramic veneers so that they are now identical. The central incisors have to be identical. So from here, we now go and change them so that they are the same width, the same inclination. They don't overlap anymore. We've added lots of little nuances of color. We can only realistically get that nuance of color coming from feldspatic porcelain. Very talented technicians can get it from Emax as well, but most of the time you get it from feldspatic. Lovely colors, different areas of the teeth, a little bit of white just up here. Again, little white patches, crack lines to try to mimic what's happening on the adjacent teeth. But again, a lovely rounded appearance and a nice smile. The central incisors totally symmetrical. So please guys, always central incisors symmetrical. Make the difference on the lateral incisors. You're going to see that in a few minutes time. Make the lateral incisors different, make them different widths, different angulations, but central incisors have to be absolutely symmetrical. Otherwise your eye line is drawn to that center line and we can see either side of it. The further away you go from the center line, the less it is easy for you to see. Again, you have to start doing this and that to see if your canines are symmetrical. We can see centrals just by one field of view. Another case, 2 central incisors going to be changed. These 2 crowns are going to be changed. And again, they're changed, creating good looking natural teeth, but also symmetrical teeth. So the key here is symmetry. Now let's move on to our lateral incisors. Okay, and our laterals have more diversity. Most of the time, your laterals are not the same. So we play on this. We play on this and make a beautiful smile look natural by changing the laterals. And what we do with the laterals, my tip for you is I make one lateral have a round incisal edge, one have a flat one. I take both my laterals, and if that is my normal inclination, like this, I will rotate one lateral 30 degrees and the other lateral 30 degrees the other way. So the rotation of them is slightly different as well. Look at the difference in shape. The central incisor, okay, we've got on the distal almost a concavity as we come out, and then huge convexity. Distal, we're flat with a smaller convexity. Let's look at the mesial. We come out mesially with a convexity. We come out mesially with a concavity. So 2 completely different shapes which need to be mirrored when you do restorations. So if anybody says, okay, I want my laterals to look the same, okay, go back to the personalities that you see on stage and screen and say, Okay, let's look at J-Lo smile. Look at the difference in the lateral incisors with J-Lo smile. Okay, one angulation's wrong or different. Look at the incisal edges. That almost looks like a canine. So let's finish our smile design part now on these two lateral incisors. You see at the moment, the two lateral incisors look more or less the same. To me, they look too wide at the moment. The centrals, again, the golden proportion's wrong. These centrals are too thin, they're too long. I can't do anything about the centrals, I'm not allowed to. All I'm allowed to do here is change the lateral incisors. So I'm going to change the lateral incisors, but I'm going to change the incisal edges and also rotate them. So here's my incisal edges changed. One round, one flat. One rotated so that the mesial comes slightly forward by 30 degrees. I'm seeing more the mesial. One rotated the opposite way, so the distal comes out a little bit more. So I see a little bit more of the distal. Subtle changes, but these subtle changes make the restorations look more natural. We've also just trimmed those incisal edges a little bit. And again, we've got feldspatic porcelain, where we've got lovely little crack lines in place here, and we've got some nice color. So your lateral incisors are the ones that will give you personality. They will make a smile look false or make a smile look beautiful and natural. So please play around with the laterals, keep the centrals exactly the same. So we're going to finish off our third part of our presentation on treatment planning in aesthetic dentistry. Is going to be talking about different ceramic systems. And we're going to go through 5 different ceramic systems that you will usually use. 4 that you'll use, or 3 that you'll probably use all the time, 2 that you may not use as much. So the 3 that you're going to use most of the time, you know, Emax, zirconia, PFL. The 2 that you may not use, and I'll talk about the advantages of using them, are feldspatic, we talked about it already, and also Captech. So let's look at the ceramic systems first of all. What is the difference between the systems? The difference between the systems is aesthetics on one side and strength on the other side. And when we go with aesthetics, we're talking about translucency with the aesthetics. And unfortunately, the most aesthetic, the most translucent is also the weakest. And we'll see here that feldspatic is the best translucent, followed by Emax, very close. And then we've got zirconia translucent, zirconia opaque, PFM, Juicera Gold, Captech. So as we go from translucent all the way to opaque, aesthetics gets worse, but also we gain strength. So you have to choose. That's why Emax and zirconia are the workhorses nowadays, because they're the ones in the middle. We want strength and aesthetics, Emax. Okay, you want strength with a little bit of aesthetics, zirconia. Okay, but don't forget the 2 extremes, which still are workhorses. So let's talk about feldspatic. We'll talk about a case here. What are the advantages of feldspatic? Okay, I've mentioned them earlier. We can do minimum preparation number 1. That can be very, very thin, ultra thin, 0.1, 0.2 of a millimeter. They're made on a platinum foil. So they can be very, very thin. The other advantage is you can bring color, and you can bring color from within. When we start to talk about Emax, Emax comes from an ingot. Okay, it's a pressed or a milled ceramic. So it starts off with one color. To start putting color now into Emax, we either have to have a coping of Emax, of which you lay down feldspatic porcelain on top. So straight away, you're losing some space. Or we have the Emax where we put color, we paint color on top, and then we get less depth perception. But feldspatic, very, very nice in a case like this, where we've got a worn dentition. We've also got some recession. Our patient's going to go through some connective tissue grafting, some perio. For those of you that watch my webinar on perio restorative work, then we went through all of these different scenarios. So please, if you not seen it, go and have a look. Perio-restorative, all the different ways in which we can improve the aesthetic result, but from a periodontal point of view. So we take her with some connective tissue grafting, we've done some whitening, the teeth are the right color. We now go and put some minimum preparation. All we've done with the teeth here are literally just round them. We've done heavy preparation off the upper canine because we've got to flip this out and give a canine guidance. We've also reduced the lower canine, but the rest of the teeth, minimum preparation. So these are, I won't say non-prep veneers, these are prep-less. Okay, don't say prepless, prep-less veneers. So no finishing lines. These are just taking away bulbosity, taking away undercuts, and rounding corners and incisal edges. So our technician can now make a very thin shell, which fits over the top. Some of them are fitted from the incisal, some are fitted from the labial. So it's a very difficult technique, not just fabrication, but also minimum preparation. Okay, it's one of those things with dentistry. The more minimal the preparation, the more difficult it is, because a technician doesn't have space. Anyway, feldspathic, ideal for two scenarios. Thin, okay, and also when we want color. So we want color here, so we can put mamelons, etc. in place, and incisal edge translucency, and also we want thinness. And there's our final case. Emacs. Let's look at Emacs. Okay, we have two types of Emacs we've mentioned, monolithic and stacked. And by stacked, we mean adding feldspathic porcelain on top. So monolithic, one color. And this is the probably the restoration of choice for those patients who want a media smile. They want one block of color all the way from centrals to sixes, beautifully white. That is one ingot of Emacs. Now, if you want to add color to the Emacs, so we're having the strength of Emacs, but also the color of feldspathic on top, you need more space because you're going to have that coping first of all, and that coping is going to be maybe 0.2, 0.3 of a millimeter, and then you're going to add feldspathic on top. So it's probably going to end up 0.7, 0.6 of a millimeter if you want to have a stacked restoration. So first of all, let's just look at the monolithic. So this is a case of monolithic. The patient's got crowns already in place. They're a horrible color. We've done some whitening so that we can get the opposing teeth the right color. Patient's already got some TMD problems, so we're making sure we're getting rid of the TMD problems. As you can see, she's a clencher and grinder. She's got wear facets everywhere. So we give her a splint, and that splint will be readapted at the end of treatment. Once a clencher and grinder, always a clencher and grinder. And when we look at strength of restorations, remember Emacs is slightly to one side of the strength, so that if I've got a clencher bruxa with Emacs, I have to put an occlusal splint in place. Otherwise, the Emacs is liable to fracture. So we're going through our diagnostics here. We're now prepping the anteriors, removing the old restorations, putting our initial prototypes in place, playing around with the prototypes until we get them so the soft tissue is correct, and then changing the prototypes through a beautiful white color. And that white color is monolithic Emacs. Obviously, as we go from feldspathic and Emacs towards zirconia and PFM, the feldspathic and the Emacs are also an adhesive restoration. Now, I know before you start shouting at me, we can also bond zirconia. It's not as easy to do, but we can now bond zirconia, and we bond Marylands. And for those of you that didn't catch it, I did a webinar on adhesive bridge work not too long ago, and we discussed the bonding protocols for zirconia bridge work. So we can bond zirconia now. Years gone by, we couldn't. So that was monolithic, one color. And the advantage is we can get bonding and adhesion. Bonding and adhesion will always give us strength, but still it's not going to be as strong as maybe zirconia or PFM. Let's go through now a stacked one. where we're going to take crowns off again, but the patient wants now a little bit more subtle color in there. So we're going to use the coping of Emax. We're then going to bond feldspatic porcelain on top to give a nicer looking, warmer, more natural color. So this is stacked. So again, we look at this situation and we can see that straight away, looking at the smile, width to length ratio doesn't look good. Golden proportion at the front doesn't look good. Lateral incisors look too wide. So we've got a whole mismatch. We're missing an interdental papilla in that area. So we've obviously got some bone problems here. So we go with our usual, okay, mounted study casts, diagnostic wax up. It's not going to be a full arch. We're going to be doing probably 2/3 of the arch. Diagnostic wax up, prototypes, preparation guide over the top of the prototypes. We have everything we need to go now and prep the case. We remove the old crowns, okay, and we're missing some canines. Those canines are in fact pontics. So we're missing canines. We go and put our new prototypes in place, and our new prototypes, you can see straight away, better width to length ratio. We took those lateral incisors in. You can see the difference between the old prototypes and where we've relined. We've got better width to length ratio. Look where we are to start off with. So we've got much better width to length ratios, as I mentioned. Those are 3-unit bridges replacing the canines. And from that, we're now going to put a couple of canine implants in. That's by the by, taking our impressions, and now we're finishing up with our final restorations. And again, our patient wanted a better, and I say better, a more natural look. Hence little white flecks, crack lines, different colors inside. So we can get all that from feldspatic. Don't get me wrong, we can also get it, and that's feldspatic on top of the Emax. We can also get it from Emax on its own, monolithic, but now we have to paint it on the surface. And it never looks as good painting something on the surface rather than the color coming from within. Remember, it's the color of the dentine which is showing, creating the color of the tooth. And that comes from within, it doesn't come from on top. Okay, let's look at zirconia. And zirconia, again, we've got two materials. We've got zirconia opaque and we've got translucent. When zirconia first came out, it was an opaque material. It was an opaque material for cemented. As the zirconia has changed, as it's developed, we've got now more translucent zirconias, which are getting to the stage where they're as aesthetic as Emax. The advantage of zirconia is you can either bond or cement. With Emax, it has to be bonding. With feldspatic, it has to be bonding. But if you're in a situation where you cannot bond for whatever reason, then you can still go to zirconia, because with zirconia, you can bond or you can cement. And of course, zirconia is going to be stronger than Emax. So more likely further back in the mouth, you choose zirconia than Emax. Anyway, let's look at opaque. Now, when do we want an opaque restoration? A little bit when we want the same thing for the Emax monolithic. It's when I want to go cemented and I'm looking at all white. And that's when the opaqueness comes in. When I want to go cemented or adhesive and I want something that looks more natural, translucent, then I'm going to go for zirconia translucent. But let's look at the opaque first of all. So we have a lady with worn teeth. You'll see in a minute. We've done our cosmetic imaging as normal. These are her teeth. She's got a little bit of wear. She's had more or less a full upper reconstruction and lower reconstruction previously. She's got composites everywhere. So this is a case where we're going to do a full mouth recon. We're going to do it at an increased vertical. This is an example of the dental facelift. So we go to our usual diagnostics, face bow, jaw registration, mounted study casts, do the lower arch waxing first of all, do it to the anatomical average curve of Spey. Then we go and do the upper wax up exactly as I've showed you previously. We have our preparation guides to help us prepare the teeth. Remember, most of these teeth have already had crowns on them. We take our prototypes and we reline them, trim them, and then cement them temporarily in the mouth. And then we do our zirconia opaque. And zirconia opaque can be really white. This is BL1 bleached white opaque. And this lady wanted everybody to know that she'd had her teeth done. It wasn't, well, I want this to look subtle, Paul. It's, I want everybody to know. If I'm paying this amount of money, everybody's going to find out that I've had my teeth done. And she wants the media smile. So laterals, same. Okay, look at the incisal edges. I don't do incisal edges that look like this if my patient is going to have a natural smile. This is only for a media smile, when all the teeth right and left need to look the same. And here's her end result of a smile, got bigger, whiter teeth. And of course, only you can say, does she look younger? For me, yes, she's thinner in the face. Okay, and is that an illusion or she lost weight? I don't know, but certainly she looks thinner in the face. We've increased the vertical dimension by 5 millimeters. So naturally, we've got a better proportion of hairline, bridge of nose, base of nose to chin. Zirconia posterior crowns, yeah, by all means. My preference would not be to have zirconia on the last tooth, in the arch, maybe a 7, etc. That's the nutcracker effect. That's the fulcrum, very close. That's where you're going to put the most stress on. We see an awful lot of PFMs where the porcelain's fractured off, but I'm happy with zirconia if the patient really wants it all the way back to the 7s. However, my preference would be to go and have either PFM or even ideally a metal or gold occlusal on the 7s. So here's our case of the posteriors all cemented with zirconia, but do remember that the odd zirconia will fail. Here's zirconia fracturing on a 6. Now, is that part of the manufacturing process which was wrong? I don't know. Is it the fact that there's large intraoral pressures from this clenching and grinding? Maybe. Was it my preparation was too sharp, not enough space? Maybe. But it wasn't very forgiving here. And we do know that some of the zirconias do not have as good a life expectancy on molars as they do with premolars. So in an ideal world, I would use feldspathic or Emax on the front teeth, okay, 3 to 3. I'd use zirconia on premolars. I'd use PFM on molars, and I'd use either PFM with a metal occlusal surface or gold on my 7s. That will give me, for me, the best aesthetic result, but also in combination with longevity. Remember, PFMs will last you on average 30 years, 28 years, if done well. Gold will last you on average 45 years, if done well. We don't have those same length of studies, longevity success rates with Emax or with zirconia. Feldspathic porcelain veneers, 90% success rate, 92% over 15 years. So we have good longevity studies with our old restorative techniques. Some of the newer ones, we don't have the same longevity. And going with longevity, also the materials are changing. So a new zirconia translucency comes out. Okay, naturally people think it's as strong. It's not as strong as opaque. And therefore, as the new materials come out, a word of warning, never be the first person that jumps in and use a new material. Always let people fail, people use it and have failures before you go in and decide when's the time is right. Translucent, okay, and another one where we're going to go with translucent porcelain because we want a little bit better aesthetics. We don't want quite that same in-your-face brilliant white. A patient who, again, has got old restorations on most of their teeth. And we're going to be doing a full upper and full lower reconstruction. Same way, mounted study cast, diagnostic waxing, lower arch first of all, prototypes, preparation guides, everything we have ready now to go into the mouth. And we go into the mouth and use our preparation guide to prepare the teeth, take our prototypes, reline the prototypes, eventually take our impressions and get our restorations made. Same thing for the upper jaw. relining, refining our preparations, putting our prototypes in place. In the lab, the definitive, this is a Geller model. Please, those of you that want to know about a Geller model, essential piece of kit, Geller model that the technician should be using. These are stone dies. The Geller model is a stone die with a acrylic base. So all the interdental papillae here, all the soft tissue, okay, all the posterior teeth that aren't being prepared at the moment, both upper and lower, they are in acrylic. It gives you the ability to adapt and trim the model. If you want more information, again, I did a webinar on lab communications, which you need to get hold of, which tells you all about the different lab techniques which we can be using. If you don't know the lab technique, then the technician will not know whether he needs to do it or not. And so probably he won't use that technique. And here's our biscuit bake. We're going to do a biscuit bake trying in the mouth, making sure that we've got our guidance exactly as we want it to be. And then it goes back to be glazed. And we now have our final glazed result. And this is a little bit more subtle, a little bit more color, more translucency in the incisal edges from zirconia translucent. Captech. Now Captech's an interesting material. Captech is porcelain fused to metal, but the metal now is an electroplated metal. So it is very, very, very thin. It's microns thin. It is not 0.3, 0.5, 0.7 of a millimeter thick as traditional metal. This is electroplated metal, which is microns thick. What it does is it gives you a base onto which to put the porcelain. What it does is it provides you with a metal finish line. And remember, metal finish lines for cemented restorations, metal collars always fit better than ceramic. Ceramic always shrinks. So you can never ever get the best looking result when you're cementing with a ceramic margin because it shrinks away. Obviously, when we're bonding, then we have composite adhesive in between there. So we get still a very, very nice bond. But if we're cementing, the ideal material next to the tooth should be metal because we'll get a better finish. Here, it's gold. But because it's only microns thick, the gold becomes invisible. So let me show you a case. This case, we're going to do porcelain fused to yellow gold, traditional PFM, but yellow gold in the upper jaw. And so we can match the color, I'm going to be doing Captech in the lower. So porcelain fused to yellow gold, that alloy is called Juicera gold, D-U-C-E-R-A, Juicera gold. And I'm going to be using that traditionally in the upper and in the lower Captech. So we look at our patient and straight away we've got problems. We're missing a tooth here. We've got a centerline problem. We've got a little bit too much tooth on display. Our lady's in her 50s, but look at the anterior occlusal plane dropping down far too much. So these teeth need to be shorter. If they're shorter, then we're going to need to do some crown lengthening here as well. Or alternatively, we're going to do some intrusion. I've got very worn lower incisors. I need to make those taller. And so by intruding the uppers will give me space to make the lowers taller. Because she is 50, 55 years of age, we'll intrude the uppers rapidly. The lowers will not over erupt as quickly, so they won't continue to make contact. So as I make the upper tooth intrude, the lower will more or less stay where it is. This was a younger person. As I intrude the upper, the lower will over erupt. But our osteoclastic activity reduce. We talked about this, okay, over eruption, osteoclastic activity on a webinar I did on Dahl appliances. If you want to go and get that one and look at that, that's a webinar on Dahl appliances to create anterior space by using the Dahl appliance. Okay, so we know what we're going to do. So in the upper jaw, full upper mouth reconstruction using Juicera gold. In the lower jaw, we're going to repair the lower incisors. We're keeping a premolar both sides. That's going to be part of bridge work. That's going to be replaced. That's going to be replaced. So we're keeping a couple of premolars in the lower, but more or less the rest is a full mouth reconstruction. Again, she's a bruxist, as you can see, clenching and grinding. The amount of wear, can you understand why we got that much wear? We got that much wear because these are over erupted. The palatal aspect has not been contoured, so it's concave. It's in fact convex, not been polished when adjusted. So now we've got the perfect, almost sandpaper effect of the uppers, over contoured uppers, rough porcelain. The lowers have been doing this forwards and backwards as a bruxist, hence the amazing amount of wear on those lowers. So we splintered her. The splint will be relined at the end of the case, or a new splint will be provided. So we have our diagnostics done already. We're going to do a little bit of crown lengthening. You've seen we've done some crown lengthening here. This is our preparation guide. We're now putting our prototypes in place. These are my Captex. So you can see the gold finish lines. You can see the gold inside. There is a gold finish line just here. So we take our worn teeth. We've done our crown lengthening. And we place our Captex on. And you can just see there is the gold finish line. Tiny, tiny finish line in gold. Some of the areas you can just see. But it blends beautifully into the soft tissue. We're taking our color from the natural premolar. So there's our natural premolar one side, natural premolar on the other side. So it's like an A3 color and a yellow gold base. Okay, that's Captec or Juicera gold. It is very, very good with those warm colors. B3s, A3s, something that's got a nice yellow or brown color in. It means we can minimize the opaque layer because we've already got that yellowish color that we're working to. So we've got more space for the ceramic. So we get a more natural, better looking appearance if we use a yellow base, gold, when we're doing a A3 or B3. We're doing something that's more A1-ish, B1 bleached, then that's better on a black. So we have a more whitish, grayish color rather than a warm yellow or brown color. And in the upper jaw, we've done, again, some orthodontics, and we're moving the teeth around, put our prototypes in place, and we've changed to Juicera gold. It's the same color, but this is now Juicera gold. So in the upper, it's porcelain fused to metal. In the lower, it's porcelain on electroplated gold. And I like the Captec, especially for lower incisors. No good for bridge work, but for lower incisors, very, very good. And there's our patient again with the splint in place at the end. So our final case, and coming to the end of the presentation, is PFM, traditional PFM. What do we get from PFM? You get longevity. You get familiarization. You get technicians who are used to using it for a long period of time. Okay, so please, when you're looking to do your restorations for your patients and you want predictability, do not always go for the most aesthetic. Aesthetic at the front of the mouth, fine. But you cannot tell when somebody smiles just by looking at their smile. You cannot tell if an upper six is Emax, zirconia, or PFM. Okay, it fades into the grayness of the back of the mouth. So use the longest lasting. For me, that's PFM. So I still like PFM. PFM for me is the only restoration that I can sleep at night with a patient being a bruxer and having PFM restorations in place. If my patient's a bruxer and got zirconia, there's a chance that zirconia may chip. If the patient's a bruxer and has Emax, there's a reasonable chance the Emax will fracture. My patient's a bruxer and has feldspatic, there is a good chance that the feldspatic will fracture. So we go with feldspatic, mandatory, you have to wear a splint. To Emax, I really would encourage you to wear a splint. To zirconia, where I think you ought to wear a splint. To PFM, where If you want to wear a splint and it gives you a better night's sleep, then that would be advisable. Okay, so various grades of wearing the splint. And that's because of two things, because of strength, and number two, longevity. We know what we're getting. So let's just talk you through a case, again, of PFM. Lady comes to you, as you can see, she's got a full mouth recon, she's got caries around the margins, she's got clefting here, so abfraction lesions, stroke abrasion, cavities, she's missing a tooth at the front. Overall, she needs a reconstruction. Lower teeth, again, very worn because of the poor palatal aspects, not the correct shape. Remember, correct concavity, shallow guidance. We mentioned this right at the very beginning of our presentation. Shallow guidance puts less stress on masticatory system. Over contoured palatal aspects, convex, flat, or rather than concave, they all make the guidance steeper. When you're brooks with steep guidance, that puts stress into masticatory systems. The teeth are part of the masticatory system. So it's very often the teeth that wear down, or it may be headaches, or it may be TMJ problems. So always we're going towards shallow guidance. So we need a full mouth reconstruction. We're going to do our full mouth reconstruction at an increased vertical dimension. We're increasing just by a couple of millimeters here, give us a bit more space so I don't have to prepare the incisal edges of my lower incisors. And again, wax up, prototypes, preparation guides, same in the lower. We're now, in terms of our protocol, the way in which we do our reconstruction, we always do uppers and lower anteriors at the same time. Again, if you want to go and review the steps involved in the full mouth reconstruction, how we do it step by step, the protocols, then I've done 4 webinars on treatment planning. 3 of those are short ones on the steps, the protocols to full mouth reconstructions. So please go and have a look at those. You'll find those webinars available. So we are now replacing the bridge work. We're doing some nice ovate pontics in these areas. Again, preparation and prototypes, relining the prototypes with Luxatemp. These are shell prototypes made by the technician. DMG product Luxatemp, trimming the margins. In the upper jaw, we're going to silver dyes, again in our Geller model. Fixed bridge work at the front of the mouth. And we take our patient from the old reconstruction to the new reconstruction. But again, PFM. So our upper goes from there to there. Lower, again, from here to here. So a lower, which has got a taller incisal edge because we've increased the vertical height. And our final full mouth reconstruction. Increased vertical dimension, strong. Does my patient have to wear a splint? No. Is my patient going to wear a splint? Yes. Okay, and the patient's wearing a splint because she gets a better night's sleep. So all my recons, I try to encourage them to wear a splint. Do I charge my patient? No. I'll throw in the occlusal splint free of charge. Why? It's protecting me from having to do any further work for them coming back and fracturing a tooth. They feel that they're getting something for nothing, which is very true. And at the end of a reconstruction, which may cost anywhere up to 50, 60,000 pounds, giving them an occlusal splint free of charge is not a big deal. So I hope you found this very, very useful. That's the end of my presentation now. I'm very happy to take some questions. So if any of you have got any questions, please write your questions down. We've got a Q&A question session now coming up. What I've tried to do during this webinar is give you the plan for aesthetic dentistry. Now, of course, aesthetic dentistry is a huge topic. As I mentioned, I've done three-hour webinars just on smile design. We've done webinars on perio restorative. We've done webinars on tooth whitening, treatment planning, the restorative case. So there's just so many different bits of information. So what we try to do here is distill it into 1 2-hour presentation that deals with a major focus, if you like, of diagnostics, of smile design, and then of choosing your ceramic. So I hope you found it useful. For those of you that have found it useful, if you want to learn any more about it, then please come to Tipton Training Limited, our website, www.tiptontraining.co.uk. We've started up our courses again, so we're now doing our full range of restorative courses, aesthetic courses, tooth preparation courses, and implant courses. All those courses are starting again between September and December. We're doing weekday courses, we're doing weekend courses, where also the courses are starting again in Dubai. We've got online courses available for you if you cannot get to the UK from all our overseas visitors. And the overseas visitors, I'd also encourage you to go and look at the British Academy of Restorative Dentistry. That's www.bard.uk.com. So yes, we have 3 questions. So I'm going to leave you now and I'm going to go and answer the questions. So again, thanks very much for listening. Please visit our websites where we've got more information about the further training that we can give you. And all our training is accredited by the Royal College of Surgeons, and the certificates and diplomas that we can do for you are all level 7. So that means you can put PG Cert or PG Diploma at the end or after your name. And then we also have an MSc course, a 1-year conversion to take the certificate and diploma up to an MSc. So all that's available through Tipton Training or through Bard. So please go and have a look at the websites. Okay, so let's go and look at the Q&A and see what questions we've got. Okay, our first question is from Fatima. Do you use semi-adjustable articulators for all your cases? And what kind of settings do you prefer, custom or average? So a really nice question there, Fatima. The answer is yes, I do. As I mentioned, do I take a face bow? I take a face bow for every case I'm doing that's an indirect restoration, where the tooth I'm doing has a contact with an opposing tooth. So if I'm doing a crown on an upper 5, for instance, or an upper 6, and there's no opposing tooth, then there's no point in taking a face bow. But for everything else, where there's a contact, I take a face bow. That means it gets put onto a semi-adjustable articulator. So that is my routine, that is my protocol, and that gives me predictability. Now, the choice of custom, average, or negative. Negatives, I seldom do. Okay, negatives are there for when you really need to do something quickly. So it's either for me custom or it's average values. If I'm doing a large case, then I'll go custom. If I'm doing a small case, so the difference between full mouth reconstruction versus 1 crown. And obviously there will be a crossover. So if I'm doing 2, 3 crowns, it's usually average. I'm doing more than that, it's usually custom. I hope that answers your question. Oh, Fatima, another question from Fatima. Do I ever perform lip lengthening surgeries for my gummy smile cases? Yes, we do. We have various ways that we can look at a gummy smile. We can use Botox. So I personally do not, but I work with a periodontist. I work with an aesthetic dentist who uses Botox and fillers. And so we have the option of either lip lengthening, pulling the lip down. We have the option of Botox, making it so it just falls down on its own. Or we have the option of crown lengthening. And you've got one of those 3. And of course, like everything in today's society, where people are more litigious, we need to gain consent. Therefore, the consent process often involves not just 1 visit, but 2 or 3 visits. As you delve in and look at different ways of doing things, then you always have to give those patients the option of 1 or more ways of doing them. And for me, Botox just means it has to be redone again, again. Simplest to do. Crown lengthening involves surgery, and obviously lip repositioning involves even greater surgery. I suppose crown lengthening versus lip surgery depends on how big the gummy smile is. If by doing bone removal, I'm shortening the amount of root in bone, I'm creating a non-advantageous crown root ratio, I'll go for gum repositioning, sorry, lip repositioning. Hope that helps. Anonymous, what is dentine hybridization? So that is dentine sealing, another word for dentine sealing. And every single case that you do, okay, I'm being very, very dogmatic now. Okay, every single case that you do where you do a crown preparation and you have exposed dentine, okay, you should go and dentine seal. Okay, hybridize the dentine, seal the dentine, and that's done with an adhesive dentine bonding agent, and that stops bacteria getting down into the dentinal tubules. Reduces sensitivity, reduces the chances of pulpal necrosis during or after tooth preparation. Fatima, I've learned a lot from you. Thank you so much. Cheers, Fatima. Nice to speak to you. Anonymous, thanks for giving your time on Saturday, Prof. Tipton. I just want to confirm if intercommissure interpupillary lines are not parallel, intercommissure line should be chosen. Correct, anonymous attendee. That's correct. Obidu, for a zirconia crown on lower left 6 or 7, patient doesn't want metallic crown visible when speaking. Do we use an occlusal splint even when we don't have TMJ issues? No, Obidu, as long as you have got the occlusal splint is to stop anterior wear or anterior fracture. So occlusal splints are made for TMD, etc. We know that. But what I'm talking about is a post-restorative splint is there to stop fracture or wear of the opposing dentition or fracture once you've done your restorations. And the worst thing in the world is going to be you've done a beautiful smile makeover, patient comes back 6 months later, I've broken this tooth. Why have they broken it? They might say that I've been chewing on a chicken sandwich. Usually it's because they've been clenching and grinding. So to stop the fracture on the anterior teeth, okay, you have, I hope, when you've been doing the crown work on the 6 and the 7, you make sure that there's no non-working side or balancing side contacts. So when the patient clenches and grinds, he cannot clench and grind on those crowns. Okay, it's the clenching and grinding which should be done on the anterior teeth, as in anterior guidance. Okay, you should be setting up 5 principles of occlusion when you're doing your cases, and that involves anterior guidance on the anterior teeth. That will disclude the posteriors. If you're discluding the posteriors, then you shouldn't need to have an occlusal splint. Okay, any more questions? I don't think so. I think that is the end of the questions, guys. Oh, I've just got one from Mahube in the Philippines. Okay, Mahube, very nice to meet you. I hope you enjoyed it. Thanks very much indeed for listening. Okay, so that's it, guys. Thank you very much indeed. I will sign off now. And we'll meet again. I have webinars next week. I'm going to do one on the periodontal prosthesis. At the end of next week, the webinars are closing down, and all of the material will then be transferred to the BARD website. So if you want to get the material there, you need to then subscribe to become a member of BARD. It's then available on the BARD website. So cheerio for now. Bye-bye. Have a good weekend.